many to mention, and we are honored to have her with us. She is an internationally recognized specialist in internal medicine, endocrinology, and diabetology. She is a medical educator, administrator, researcher, and writer with over 28 years of experience in mentoring and training medical students, resident doctors, and other healthcare professionals. She has vast experience in curriculum development and review, and has functioned in numerous positions in this capacity, as well as being an editor-in-chief of the African Journal of Endocrinology and Metabolism. She's a lecturer in internal medicine and also endocrinology and diabetology. She has functioned in numerous levels of leadership and has immense knowledge in global health practices. It is my honor to welcome Professor Anumah. Ladies and gentlemen, please welcome Professor Anumah. Can we unmute her so she can speak?
Okay. Good afternoon, everyone. Thank you for inviting me to speak with you this afternoon.
Welcome, Prof. Good afternoon.
Thank you.
We yield the floor to you, ma'am. Yes.
So I can share my screen.
Can we stop sharing so that Prof can share her slides, please? Okay, great. You can share now, Prof.
Okay.
So Prof will be sharing her slides now. Please remember to chat in the questions you might have while she's on and while she's presenting, and she would take them right after. Thank you.
Okay. Are you seeing my screen?
Not yet, Prof. Okay, it's coming up.
Can you see it now?
Yes, it's up now. Just need it in presentation mode and you're good to go. Yes. Awesome.
Okay. So thank you very much once again. You are hearing me clearly?
Yes.
Yes, we can.
Loud and clear. Yes.
Okay. Okay, fine. So I'm talking about diabetes, getting a grip on the highs and the lows. Okay, and the outline will go this way. A little bit about diabetes as far as introduction is concerned. 1 or 2 slides on epidemiology, criteria for diagnosis, consequences of hyperglycemia, principles of management, hypoglycemia, consequences of hypoglycemia, treatment and prevention. So, what is
Prof,
I think you're muted.
You need to unmute yourself. Yes. You need to unmute yourself.
Can you hear me now?
I can
Yes,
hear
you
you.
can.
Thank you. Yes.
Okay.
Yes.
So what is diabetes? It's simply high blood glucose levels. That is what we call hyperglycemia. And simply defined, diabetes is when the body loses the ability to utilize glucose properly. So these are the cells and this is glucose, but there is a block, so glucose is not able to enter the cells for utilization as a source of energy and nutrition. And that could be because of insufficient insulin production, defect in insulin action, or both, resulting in abnormal carbohydrate, fat, and protein metabolism. So diabetes is not just a problem with carbohydrate metabolism. Fat metabolism has a problem, protein metabolism has a problem as well. And that's why at the end of the day, it appears like a complex disease, because it's not just affecting one area. Okay, so when we want to use the key and lock analogy just to be able to explain what we are talking about, in the normal situation, okay, the pancreas is here. So the B cells from the pancreas produce insulin, which we term the key in this situation. And then these are the cells, glucose is here, but we need the key to open the door for glucose to enter. Now, in type, that's what happens in the normal situation. So glucose is able to enter the cells because we have the key. Now, in type 1 diabetes, of course, before patients present with type 1 diabetes, they have, destruction of the B cells as much as 90%. So they are virtually not producing any insulin at all. So no key. And because of that, no key to open the door, so glucose cannot enter and therefore remains in the blood. Now, in type 2 diabetes, what happens? We have the key, but there's a problem at the entrance. There is resistance. And therefore, even though we have the key cannot open the door remains locked, so glucose cannot enter the cell to be used for nutrition and source of energy. Just a little bit about classification. We have type 1, B cell, total B cell destruction, leading to absolute insulin deficiency. So in type 1 diabetes, there's absolute insulin deficiency. There is no residual B cell activity at all. But in type 2 diabetes, we have both insulin resistance and B cell dysfunction. Then we have other types, that's diabetes that can occur as a result of some other conditions, like chronic pancreatitis or cancer of the pancreas, endocrine disorders, and so on. We can have diabetes arising from these conditions. And then we have gestational diabetes, which is diabetes, blood sugar getting high for the first time during pregnancy, as opposed to diabetes in pregnancy, meaning this person had diabetes before and becomes pregnant. So, well, looking at epidemiology, we know that we have a problem because diabetes is rising every day. 1 in 2 adults with diabetes are undiagnosed. And, presently we have 463 million people with diabetes, and by 2045 is estimated that 700 million will have diabetes. That's a big problem because in Nigeria, for example, we know the structures we have are not sufficient to handle, the increase in the prevalence. And unfortunately for us, 80% of this increase is expected in our own environment in low and middle income countries. And that's why it's a big problem for us. So, in 2019, 4.2 million people died from diabetes. And of course, Nigeria contributed to this global figure. I think we can go to the next slide. So, I think it's nice to look at diabetes story in Nigeria. 1 out of every 13 adults in Nigeria is said to have pre-diabetes. Well, 2.7 million people had diabetes, which is about 3% as at 2019. But I can assure you that this is underreporting. We know the problem we have with data in Nigeria. So there are many more people with diabetes in our environment than this figure reported by the International Diabetes Federation. But by 2045, you can see the kind of increase that we are expected to have. More than 143% increase in the prevalence of diabetes. And that's a big problem that is staring at our doorstep. It's a time bomb. And if we don't do something about it, we're going to get there and we will all be stuck. Just a little bit about, what is happening when we have hyperglycemia. It's a multi-systemic disease. You can see from this figure that it's not just one defect that we have. We call this the ominous octet. Okay, hyperglycemia results from so many defects. We have the incretin effect in the GI, which we all know about. When we take glucose orally, we have more insulin secretion than when it is injected IV because of the incretin effect, okay, that stimulates the B cell to produce insulin. And in diabetes, sorry? I think there's some noise at the background.
If you're not speaking.
Yes. Okay. So the problem in diabetes is that, like we said, that diabetes is not just about carbohydrate. It involves fat, abnormality, it involves protein. There is increased lipolysis. Usually what insulin will do is to encourage lipogenesis. So triglycerides are stored in the fat cells, but when we don't have sufficient insulin, there is breakdown of triglycerides into fatty acids into the circulation. There is increased glucose reabsorption in the kidneys. I mean, there was in the pre-quiz, one of the questions was that in type 2 diabetes, there is increased glucose reabsorption. So that's the answer there. We also have decreased glucose uptake in the muscle. We have neurotransmitter dysfunction, increased hepatic glucose production, because what insulin does is to keep the liver quiet. Now, when you don't have sufficient insulin, then the liver is so busy breaking down glycogen into glucose and making glucose from non-glucose substances. We also have increased glucagon secretion from the alpha cells in the pancreas. And then, so you can see that there are so many problems, in patients who have diabetes. Now, let's look just a little introduction about, what diabetes is all about. But now we can look specifically at the topic, which is what are the highs and what do we do with them? How do we handle them? Okay, so first of all, when glucose is high in the blood, the patient experiences some things. But I must say here that it's not all patients that will have symptoms. There are patients that are completely asymptomatic. And it's only when they do, medical check for one reason or the other that we discover blood glucose is high. Then there are those who present, with some of the classical symptoms like frequent urination, excessive thirst, excessive hunger, feeling very tired. And then some will present with the chronic complications of diabetes for the first time, sores in the wound, sores that won't heal, or vaginal infections, recurrent infections, unexplained weight loss, of course, excessive weight, numbness, tingling of the feet, blurred vision, and so on. So there are those who present with the chronic complications. There are those who have no symptoms. There are those who present with the acute complications. I mean, they suddenly collapse in the office or at school. And when they get to the emergency room, blood sugar is, getting to the skies. And then there are those who will present with the chronic complications. So it's not one cap fit all. And the danger of diabetes is that it can be particularly for those who are not symptomatic. Pre-diabetes, for example, in that state, patients can develop both the macrovascular and the microvascular complications. So somebody can say, I don't have diabetes, but presents with a myocardial infarction or presents with a stroke. Now, how do we make the diagnosis? When we have fasting blood sugar in anybody more than 7 millimoles, or we have a 2 hours postprandial more than 11.1 millimoles, then we make a diagnosis of diabetes, or HbA1c equal or greater than 6.5%. Now, if we have high blood sugars in patients who are not symptomatic, then we need to repeat a second time before we label that individual diabetic, because before we label anybody, for us to look at, that.
Dr. Anumah, Professor Anumah, you're muted.
Yes.
Did we just lose Prof?
We just did, yes.
Yes. Okay, I'm sure she'll be joining in a second.
Yes.
So Prof will be joining us in a second. We're giving her a call. We all know what network is like in this environment. Okay, Prof, welcome back to the call. You're muted, so if you could unmute and continue sharing, and we'll love to hear the rest of your presentation.
Okay. So, are you hearing me now?
Yes.
Okay. Where were we? Should I go to the previous slide, or this is fine?
I think we can start from the previous slide.
The previous slide, okay. Okay, so we were talking, the previous slide was talking about diagnosis. And we said when we have a fasting blood sugar in anybody 7.0 and a 2 hours 11.1, we make a diagnosis of diabetes, or a HbA1c level greater or equal to 6.5%. But that when you get, these blood sugars in anybody for the first time and there are no symptoms, then we need to repeat a second time before we label an individual having diabetes, because it's a lifetime disease. Now, this slide, this is one of the landmark studies done in type 2 diabetes, showing us the meaning of having high blood sugars, what it means. That the higher the HbA1c level goes, the higher the complications of diabetes, both microvascular and macrovascular. So this is why we don't sleep over the blood sugar of patients, because the complications will not sleep with us. So we must make sure that we have good control in our patients, because this is very clear. We can see that the higher the HbA1c, the more the microvascular complications, that's, neuropathy, retinopathy, nephropathy, and the more the macrovascular complications, example is myocardial infarction. So the consequences of hyperglycemia, of course, it will increase morbidity and premature mortality. The macrovascular complications, like I said earlier, include ischemic heart disease, stroke, and peripheral vascular disease. And the microvascular complications include retinopathy, nephropathy, and neuropathy. So these are the various target organ damages that occur in diabetes. Okay. We can see the blood vessels, the problem we have at the level of the blood vessels, vasoconstriction, vascular hypertrophy, endothelial dysfunction, and atherosclerosis. So this explains all the vascular complications of diabetes that we have. Of course, hypertension. 70%, 60-70% of our patients with diabetes are also hypertensive. And then in the kidneys, of course, nephropathy with proteinuria, albuminuria, glomerulosclerosis, and decreased eGFR. In the heart, we have apoptosis, left ventricular hypertrophy, and fibrosis. Of course, in the brain, stroke, cognitive dysfunction, also arrhythmias, heart failure, and all that. So we can see that there is no organ in the body that is spared, by diabetes. So it's a complex disease, and we must treat it as such. In Nigeria, everybody assumes they can treat diabetes, but it is not so. It is a complex disease. Now, diabetes is the leading cause of death the leading cause of death in people with diabetes is cardiovascular disease. And we can see that 52 to 80%, of deaths in diabetes is due to cardiovascular disease, 10 to 20% is due to renal disease, and 15% due to cerebrovascular disease. So type 2 diabetes doubles the risk of cardiovascular disease as compared with adults without diabetes. Okay, I just want us to see this slide and see the journey, the progression of type 2 diabetes, for example. Okay, the red one is insulin resistance. So you can see as the years go by, insulin resistance increases. The green one is B cell activity. So B cell function keeps reducing, keeps going down. Insulin level, you know, the incretin effect also keeps reducing. And the fasting blood sugar keeps rising, and the postprandial blood glucose keeps rising. If you see, this slide is so important because of these two. If you look at it, in the pre-diabetes state, the pre-diabetes state consists of two groups, impaired fasting glucose, people with impaired fasting glucose, and people with impaired glucose tolerance. If you look at it, this is the diagnosis. This is the time of diagnosis. But you can see that even before the diagnosis, there is, macrovascular complications start and followed by microvascular complications. So this explains why somebody has a heart attack and says he doesn't have diabetes, but you go and check and discover that diabetes had blocked the blood vessels, for quite some time. This is also very important for us to know that even before the diagnosis, you can see that 60% of B cell activity had gone before the diagnosis. So, and if you look at it, it's a progressive course. So B cell activity keeps going down until it becomes zero here. And that is why at 6 years, more than 50% of patients with type 2 diabetes will need insulin therapy to be able to get to target and reduce the burden of complications. This slide is important for us to see that the contribution of fasting plasma glucose and postprandial glucose in HbA1c value. So at lower values of HbA1c, postprandial blood glucose values contribute more. And at higher HbA1c values, it is the fasting blood glucose that contributes more to the HbA1c value that we get, when we check these patients. And this has a bearing to how we adjust whatever medication we have put these patients on, either to handle fasting blood sugar or to handle postprandial or to take care of both. Sorry. And these are the consequences of postprandial hyperglycemia. So, and it's so important for us to take note of this because many places, I find out that they manage these patients with fasting blood sugar only. You cannot manage a patient, a diabetes patient with fasting blood sugar only. You can't make any statement about, the state of control if you don't know what the 2 hours postprandial is doing. Now you can see the consequences of high postprandial values. It will cause cardiovascular disease, increased mortality, increased cancer risk, impaired cognitive function, decreased myocardial blood flow, neuropathy, retinopathy, and so on. So we can see the consequences of postprandial hyperglycemia, and that is why we must be checking the postprandial blood glucose. Fasting blood glucose is not enough to assess the control in anybody with diabetes. So what do we do? How do we manage hyperglycemia? Well, it's a multidisciplinary team management and includes, of course, the endocrinologist or the diabetologist, the diabetes educator, the diabetes nurse, the pharmacist, the dietitian, podiatrist, orthotist, the physiotherapist, the ophthalmologist, the nephrologist, cardiologist, surgeon, and psychologist. So you can see diabetes is a complex disease. It's a big problem. So let's not trivialize it in our patients that we manage. And at any point in time we get stuck, we don't know, we are not sure what to do, please let us send this patient to where the patient will get help. It's very important. I'm always saying this because of the experience we have in the tertiary institutions. Patients will remain with a particular setting for 10 years, 15 years. Then by the time they are sending this patient to us, this patient has gangrene of the foot, this patient has end-stage renal failure. What do we do at that point? There is nothing much we can do for these patients. You can see that it is a complex disease. So please, when you are not sure of what to do, for the sake of that human being, for the sake of that life before you, that life before you is as precious as your own. Send this human being to where this human being will get help, and send him or her timely. Now, what is our goal? Our goal in managing hyperglycemia is to eliminate, first of all, to eliminate symptoms and improve the well-being of that patient. Of course, if anybody has severe hyperglycemia, will be unwell. So we want to eliminate the symptoms and improve the patient's well-being. We want to prevent or retard the microvascular complications that we had already enumerated. We want to optimize glycemic control and target blood pressure levels. We want to reduce macrovascular events by targeting blood pressure levels, by targeting the lipid levels, optimizing blood glucose levels. And psychological care is very important. I mean, it's not, like I said earlier, that before you make a diagnosis of diabetes in a patient, you must be very sure. It's a lifetime disease. It takes a lot from these patients. So sometimes they get what we call diabetes distress. So they need some psychological, support, counseling, and all that. So what are the principles of management? Dietary modification, very important, because we have seen the problem. That the problem is that we don't have sufficient, the patients don't have sufficient insulin to handle whatever they take in as a source of energy and nutrition. So part of how we can, manipulate management in this patient is also to look at what this patient is taking in. Then, of course, physical activity, exercise, diabetes care, patient education and counseling. Diabetes education is so important. It is the most important thing because we need to empower this patient to be in charge, not the other way around. Doctors are not so good in educating patients because perhaps for pressure of time and so on. Outside this country, we have trained diabetes educators that will do that job while we see, the patients in order to take care of, other aspects of management. And that is why I want to seize this opportunity to say here that we are starting a program in the University of Abuja in Masters in Diabetes Education, because we have seen that in this country, we don't have certified diabetes educators, and it's very important. It's a very important aspect in diabetes management. So people are going to have master's degree certified as diabetes educators. So clinical monitoring and follow-up, very important. And when we talk about diabetes education, is like an ocean that contains all manner of things to empower the patient at the end of the day. I'm always telling patients that what we desire really is that 50% of the time they are their own doctors. So we need to
Prof, drop off. Prof, we can't hear you. So I'm sure that her network is a bit shaky. I'm sure she'll be with us shortly. Still a bit shaky, Prof. So please do chat in your questions in the chat.
These patients to target fasting plasma glucose, and then pharmacological treatment and managing complications. We talk about diabetes education targets in major guidelines. ADA, that's American percent. IDF, International Diabetes Federation, less than 7%, and AAC, that's the American Association of Clinical Endocrinologists, they are a bit stiffer, less than 6.5%. Now, approach to treatment, type 1 diabetes. What is not there is insulin, so we don't play around with any other thing, we treat them with insulin. Type 2, we can give oral drugs, we can give insulin, and we also have non-insulin injectables. What are the sites of action of anti-diabetic medication? I don't know if this slide is clear, but if you look at drugs that slow gastric emptying or carbohydrate absorption, we have GLP-1 analogs, metformin, alpha-glucosidase inhibitors. Drugs that increase hepatic insulin sensitivity, metformin, and the TZDs. Drugs that decrease glucagon secretion, we have the DPP-4 inhibitors and GLP-1 analogs. Drugs that increase satiety, GLP-1 analogs. Drugs that increase muscle insulin sensitivity, the TZDs and metformin. Those that increase adipose tissue insulin sensitivity, the TZDs, and those that increase insulin secretion, GLP-1 analogs, DPP-4 inhibitors, the sulfonylureas, and the glinides. Those that increase renal reabsorption, we have the SGLT2 inhibitors. Those are new drugs that are just coming into the country. And when we look at, the anti-diabetics and their route of administration, the biguanides, they are oral, SGLT2 inhibitors, they are available in Nigeria now, they are oral, GLP-1 analogs, they are injectable, DPP-4 oral, TZDs are oral, sulfonylureas are oral, insulin is injectable. Now, this is just to show us the profile of, insulin, the various insulins that we have. The short-acting ones, that's like Actrapid, we can see it rises up immediately and then it goes down. It handles postprandial, because when we eat, we have immediate postprandial hypoglycemia. So fast-acting insulin will handle it. But we have the rapid-acting, which even gets to the peak faster than, the Actrapid. Actrapid is human insulin, but rapid is insulin analog. And we also have them available in Nigeria. Then we have NPH, which is the intermediate acting, rises gradually to a peak and then takes this number of hours to get to, the lowest peak. Then we have analogs like, insulin glargine, that's Lantus. It has no peak. It is for basal supply of insulin, so fear of hypoglycemia is not there. We also have Detima, which is also insulin analog as basal. And look, we can see the profile is similar to Lantus. In that the patient needs. So what are our treatment options for type 1 diabetes? How do we go about, handling them? Once you make the diagnosis, there is no playing around with diabetes education and then insulin therapy, basal plus, short-acting ones to handle immediate postprandial hyperglycemia. Now for type 2 patients, we have, oral medications. If we put on one single medication and they are not getting better, we can improve, we can combine dual or even triple. But we can, when we look at the slide I showed on the cause of the disease, we can see that if a stage comes where this patient needs insulin, either as a supplement or as a substitution. And we must not waste time when our patients get there. Now, this is guideline in the EASD, IDF, and so on, guideline to show us the stepwise approach. When you get this patient, particularly for type 2 patients, you put them on insulin as first line. If in 3 months they are not getting to the target we had discussed, you add the second medication. And if in another 3 months this patient is not getting to target, we add the third one. And if we're not still succeeding in where we want to get to, we add insulin, either as a supplement, like I said, or as a substitution. This is the ADA-ESD 2015-2018 guideline. Okay, we start with metformin, and then if we don't have good blood sugar, we can add any of these. And if we are still not having, we can add another drug. And if we need to get to the last stage where we can combine with oral drugs, or we can substitute insulin, or we can give GLP-1 analog. Sorry, my time is short, so I can't explain too much. Majority of guidelines target postprandial blood glucose less than 7.8 millimoles for us to beat our chest that we have, good control in that patient. So for ADA, ESD, less than 7. Okay, HbA1c with this postprandial value. For AACE, less than 6.5 with less than 7.8 postprandial value. For IDF, less than 6.5 with less than 7.8 millimoles as postprandial value. So we can see is that the stiffer the control, the better. But then we individualize our approach. It is not one cap fit all, so we don't cause problem for some patients. So we have to evaluate the patients critically and individualize what we are going to do depending on the peculiarity of the patient. There are patients we are very stiff, in the control. Then there are patients we relax, the stiffness, in getting to target. For example, if we have risk of hypoglycemia or, drug adverse effects, if it is low in that individual, then we are more strict. If it is high in that individual, we relax a bit. The duration of diabetes, if it is newly diagnosed, we are more strict. But if it's a long-standing diabetes, we are not so strict. And life expectancy is short, we are not so strict. If the patient has comorbidities, then and life expectancy is long, then we are more strict. If the patient has established vascular complications, if it is absent, we are more strict. If it is severe and life expectancy is short, we are not very strict. Also, it depends on patient's attitude and expected treatment efforts. If you have a patient who is well motivated, then you can, intensify whatever you are giving to that patient. For example, insulin, when we get very well motivated, energetic patients, we can put them on both, basal and pre-meals, okay, so that we can have, very good control and we can reduce the burden of complications. And of course, in our setting, resources and support system is very important. And this is where we score very low in this country as regards diabetes management. Okay, so this slide is just showing the advantage that we can have.
You have 5 minutes more, Prof. Sorry to interrupt.
Okay, so this is showing the advantages we can have when we have a 1% reduction in insulin in HbA1c level. Now the lows, very important. This is very, very important because there are patients who die suddenly at night. Then everybody wakes up and say, oh, we don't know what happened to him. He was okay yesterday. That patient may have had hypo during sleep. Now, what is hypoglycemia? It is low blood sugar, below 3 millimoles. And in diabetes, a level of 3.9 often is regarded as low because the autoregulation has been set at a high level. So they can actually have hypoglycemia at a higher level than what we define as hypoglycemia. And of course, these are the, how we diagnose hypoglycemia, we must have that triad. Hypoglycemic symptoms, then biochemically proven with the level and relief of symptoms with administration of glucose. Now we have various levels of hypoglycemia. We can have level 1 less than 3.9 with no symptoms, level 2 less than 3 with symptoms, and then but can treat him or herself with cognitive function intact. Then we have level 3 where there is cognitive impairment and requires help, okay, from another person to get treated. And what are the causes? Rarely ever spontaneous. It occurs more in older people with renal impairment, long duration of diabetes, low HbA1c, prior hypo, alcohol consumption, and hypo unawareness. And it can result from mismatch between drug use. Okay, for example, if we are giving insulin and that same patient is on sulfonylurea, that patient can have hypoglycemia. When there's little food consumed or missed meals and the patient takes his medication, or exercise, recent exercise or unplanned or strenuous exercise can induce hypoglycemia. These are the agents that are associated with the greatest risk of hypoglycemia: insulin, sulfonylureas, the glycines, and then drug-drug interactions can also potentiate hypoglycemia. Those that are unlikely are drugs like metformin, the incretin mimetics, DPP4 inhibitors, GLP-1 analogs, the TZDs and alpha glucosidase inhibitors. It's very important to look at this slide, the symptoms of hypoglycemia. We have a responsibility to teach our patients these symptoms. So we ourselves must know them, and then we tell them that if you notice any of this, it means that your blood sugar is getting low and you must quickly do something about it. Okay. Now, what are the consequences of hypoglycemia? Very important. Okay, cardiovascular complications. It can actually worsen ischemia in the heart. People can decide to be eating and then they have excessive weight gain because of, they're afraid of the symptoms of hypoglycemia, particularly severe hypoglycemia. When people get it, they don't want to experience it the second time. And then they can have, increased risk of seizures, loss of consciousness. They are admitted in hospital severally for that. If they drive, increased risk of accidents, reduced quality of life. When a patient is having hypoglycemia all the time, the quality of life is reduced. Of course, increased risk of dementia, very important in the elderly. That's why we must be very careful when we are treating elderly patients to make sure that we don't tip their blood sugar too low to prevent hypoglycemia. And of course, death. There are patients who have died, like I said earlier, from hypoglycemia. So how do you treat it? Ingestion of glucose or fast-acting glucose, 15 grams of fast-acting carbohydrate or glucose on the immediate, particularly if it's not severe and the patient can help him or herself. And then if it is severe, of course, this patient is taken to hospital and we have to give parenteral. We also teach patients where they can afford to get glucagon injection, and they are taught how to inject themselves so that when they feel symptoms of hypoglycemia, they are in a meeting at a conference, they can inject glucagon. Now, if it is quite severe, like I said, we have to admit the patient and give IV dextrose. So preventing hypo, we need frequent monitoring. We have to avoid, educate the patient to avoid missing meals. Use more of metformin, incretin mimetics than sulfonylureas or glenites, especially in the elderly. We have to titrate insulin dose carefully so we don't cause hypo. And then the patient, I usually say that there is no quality management of diabetes if the patient is not encouraged to have, a meter to monitor his or her own blood glucose, to be part of his or her own management. Of course, cautious exercise, they must check their blood sugars before they go to exercise. And then they must be careful about fasting. The patients must be examined and certified fit to fast. So it is not all our patients that are fit to fast, and careful drug combination. So we have to have a balance. Here we are highs on this side, lows on this side. Okay, so the fear of hypoglycemia is there, the problem with weight gain is there, having adequate HbA1c. So we have to be able to titrate, balance things so that we have good control in our patients and we can avoid them, having either high or low, then we reduce the burden of complications in them. Barriers to quality of care. Irregular supply of medicines is a big problem in our setting. We are familiar with it. Inadequate healthcare infrastructure and disproportionate distribution of facilities. Affordability, lack of adequate training and retraining of healthcare providers. And that's why I praise Kendra and her group for this, continuous medical education that they are doing. Lack of education to people living with diabetes and their families, and then different government priorities. What are the peculiar problems we have in Nigeria? Ignorance, leading to delay in diagnosis. Of course, many come to us with chronic complications of diabetes and they say they didn't know that they have diabetes. Poverty, we run a cash and carry health system. Our national health insurance is still struggling. And the problem with alternative Medicare, we know that, we're very familiar with that in Nigeria. They tell you they can cure diabetes and many patients prefer to believe them. Poor healthcare delivery system. The structure, we have a problem, organization, we have a problem, and we have few specialists, in Nigeria. Suboptimal adherence of patients to lifestyle and pharmacological agents. Of course, fake and ineffective drugs. So these are the peculiar problems we have in Nigeria that is mitigating against quality diabetes care in this country. So management of diabetes is the art of the possible. You must educate the patient. I tell the healthcare providers, if you know you won't have the time to educate a patient, leave that patient alone, send the patient somewhere else where the patient will be empowered. This is just an abstract to show you the impact of education, in preventing food care, diabetes food in University of Abuja Teaching Hospital. with diabetes foot care in this study, we were able to reduce amputation from 50% in 2009 to 10% by 2017, both amputation rate and admission rate. We're very proud of this study because it just shows you that if we, invest in empowering these patients and educating them, we can actually prevent and reduce the burden of complications that our patients present with. Thank you very much.
Thank you so much, Prof. That was such an educating and interesting lecture, all in one. Thank you.